Hello, my name is Ayushi Ranjan, roll number 23, and my topic is antihypertensive drugs. Classification of antihypertensive drugs. Angiotensin converting enzyme inhibitors: captopril, enalapril, lisinopril, perindopril, ramipril, benzapril, fosinopril. Number second, angiotensin 2 receptor blockers: losartan, candesartan, irbesartan, valsartan, telmisartan, olmesartan. Number third, direct renin inhibitor: aliskiren. Number fourth, calcium channel blockers: diltiazem, verapamil, nifedipine, amlodipine, nicardipine, isradipine, felodipine, nitradipine. Number fifth, diuretics, of which first is thiazides and related agents: hydrochlorothiazide, chlorthalidone, indapamide. Number second, loop diuretics: furosemide, bumetanide, torsemide. Number third, potassium sparing diuretics: amiloride, triamterene, spironolactone, apleronone. Number six, sympatholytic agents, of which first is centrally acting sympatholytics: clonidine, alpha methyl dopa. Number second, beta adrenergic blockers: atenolol, metoprolol, esmolol, betaxolol, cartiolol, propanolol, timolol. Number third, beta adrenergic blockers with additional alpha blocking activity: labetalol, carvedilol. Number fourth, alpha adrenergic blockers, of which there are two types: selective and non-selective. Selective are prazosin, terazosin, doxazosin, and non-selective are phenoxybenzyamine, phentolamine. Number fifth, ganglion blocker, trimethophan. Number sixth, neuron blocker, reserpine. Seventh, vasodilators, of which first is arteriolar dilators: hydralazine, minoxidil, diazoxide, phenoldopam. Number second, primarily venodilator: nitroglycerin. Number third, arteriolar and venodilator: sodium nitroprusside. Angiotensin converting enzyme inhibitors. Angiotensin converting enzyme inhibitors, or known as ACE inhibitors, are frequently used as first line antihypertensive drugs. Mechanism of action: angiotensin converting enzyme inhibitors. Number first, inhibit the generation of angiotensin 2, resulting in dilation of arterioles, which further decreases peripheral vascular resistance, decreasing blood pressure. Decrease in aldosterone production, which causes decrease in sodium and water retention, and which further decreases blood pressure. Decrease in sympathetic nervous system activity. Number second, inhibit degradation of bradykinin, which is a potent vasodilator, by angiotensin converting enzyme. Number third, stimulate synthesis of vasodilating prostaglandins through bradykinin. All these actions contribute to their antihypertensive effect. They also reverse ventricular and vascular hypertrophy. Their pharmacokinetics: angiotensin converting enzyme inhibitors are usually given orally. In hypertensive emergency, enalapril can be given IV. Food reduces the absorption of captopril, hence it should be given 1 hour before meals. ACE inhibitors poorly cross the blood-brain barrier, are metabolized in the liver, and excreted in urine. Adverse effects and contraindications. Number first, cough is due to increased bradykinin levels in the lungs. Appearance of intracerebral cough is an indication to stop the drug. It subsides following discontinuation of the drug. Number second, angioedema, swelling in the nose, lips, mouth, throat, larynx, and glottis. There can be airway obstruction. Patient's airway should be protected. If required, adrenaline, glucocorticoids, and antihistamines should be administered. Number third, proteinuria can occur rarely. The drug should be discontinued. Number fourth, teratogenic effect, resulting in growth retardation, fetal hypotension, renal failure, and neonatal death. Hence, contraindicated in pregnancy. Number 5. Hypotension may occur following the first dose of ACE inhibitor. This can be marked in patients who are volume depleted or have chronic heart failure. Number 6. Neutropenia is rare. 7th. Rashes. 8th. Itching. Discontinuation of the drug is not required. Number 9. Loss of taste sensation, also known as dysgeusia. Number 10. Hyperkalemia. In patients receiving ACE inhibitors, hyperkalemia may occur in the presence of renal insufficiency or when they are combined with potassium sparing diuretics. Angiotensin converting enzyme inhibitors are contraindicated in patients with bilateral renal artery stenosis, as acute renal failure can be precipitated. It maintains glomerular filtration rate by constriction of efferent arteriole. Angiotensin converting enzyme inhibitors are also contraindicated in patients with single kidney with renal artery stenosis, as they can precipitate renal failure. Drug interactions: ACE inhibitors and potassium sparing diuretics. Simultaneous administration of these drugs can cause dangerous hyperkalemia. ACE inhibitors and lithium. ACE inhibitors retard renal elimination of lithium and potentiate its toxicity. ACE inhibitors and NSAIDs. NSAIDs, by inhibiting prostaglandin synthesis, promote sodium and water retention on chronic use. Thus, they decrease the antihypertensive effect of ACE inhibitors. Thiazides and ACE inhibitors. Diuretics increase the antihypertensive effect of ACE inhibitors by promoting the loss of sodium and water. Serum potassium levels are maintained by the combination. Therapeutic uses of ACE inhibitors. Hypertension. ACE inhibitors are used in all grades of hypertension. They decrease cardiovascular and cerebrovascular morbidity and mortality. They do not cause electrolyte disturbances, hyperuricemia, alterations in lipid level, and sexual dysfunction. They are preferred in hypertensive patients with diabetes because they delay or prevent progression of renal complications. They are also preferred in hypertensives with coexisting chronic heart failure, left ventricular hypertrophy, and peripheral vascular disease. Acute MI. ACE inhibitors should be started within 24 hours in patients with MI. They have shown both short-term and long-term improvement in survival and decrease in reinfarction. Congestive heart failure. ACE inhibitors should be prescribed to all patients with impaired left ventricular function. Diabetic nephropathy. ACE inhibitors and angiotensin II receptor blockers are the preferred drugs in diabetic nephropathy in hypertensive as well as normotensive patients. They decrease systemic blood pressure and dilate renal efferent arteriole, thus causing decrease in glomerular pressure, inhibit angiotensin II mediated mesangial cell growth, thus they decrease microalbuminuria. Scleroderma renal crisis. ACE inhibitors prevent the effects of angiotensin II in the renal artery. Thus, they are effective in the treatment of scleroderma renal crisis. Survival rate is increased. Angiotensin receptor blockers or angiotensin receptor antagonists. They are losartan, irbesartan, candesartan, olmesartan, valsartan, and telmisartan. The two types of angiotensin II receptors are 81 and 82. Most of the effect of angiotensin II are mediated by 81 receptors. They are vasoconstriction, aldosterone secretion, and the release of noradrenaline from sympathetic nerve endings. The role of 82 receptors is not known. Angiotensin receptor blockers competitively inhibit the binding of angiotensin II to 81 receptor subtype and block its effects. Angiotensin receptor blockers produce effects similar to those of ACE inhibitors. Angiotensin receptor blockers do not affect bradykinin production. Adverse effects. Angiotensin receptor blockers are better tolerated as compared to ACE inhibitors. They cause headache, hypotension, weakness, rashes, nausea, vomiting, and teratogenic effects. They may cause hyperkalemia in patients with renal failure or in patients with potassium sparing diuretics. They are less likely to produce cough or angioedema than ACE inhibitors. Uses: angiotensin receptor blockers are used in hypertension, congestive cardiac failure, MI, and diabetic nephropathy. The antihypertensive efficacy prevent of ARB is comparable with that of ACE inhibitors. Like ACE inhibitors, ARBs prevent or delay the development of renal complications in diabetes. Angiotensin receptor blockers are mainly indicated in patients who develop cough with ACE inhibitors. In chronic cardiac failure and MI, ARBs are used in patients who are intolerant to ACE inhibitors. Direct renin inhibitor, L-ischyrin. L-ischyrin, by inhibiting renin, decreases level of angiotensin 1 and angiotensin 2. It is useful in hypertension in combination with diuretics. ACE inhibitors or ARB increased antihypertensive efficacy. It is administered orally. Adverse effects include diarrhea, abdominal pain, headache, and angioedema. Diuretics. Thiazide and related drugs are widely used drugs for uncomplicated hypertension. Chlorothiazide, hydrochlorothiazide, and chlorthalidone are the commonly used thiazides. Thiazide diuretics. These are used in uncomplicated mild to moderate hypertension and have a long duration of action. They should be administered in a low dose, that is 12.5 mg of chlorthalidone or hydrochlorothiazide. If the antihypertensive response is not adequate, the dose can be increased up to 25 mg per day. Beyond this dose, thiazides are not safe. Potassium-sparing diuretics are usually given with thiazides to counteract potassium loss and increase antihypertensive efficacy. Use of ACE inhibitors with thiazide decreases potassium loss by thiazides and enhances antihypertensive effect. Advantages of thiazides: they have long duration of action, are cheap, and well tolerated by elderly patients. They decrease the incidence of fracture in elderly patients by reducing urinary calcium excretion. They have synergistic effect when used in combination with other antihypertensive drugs. Chlorthalidone is a frequently used thiazide-like diuretic in hypertension as it has a long duration of action. Indapamide and metolazone are more potent, longer acting, and produce fewer adverse effects than thiazide. Loop diuretics. These drugs have short duration of action, so a sustained potassium deficit is not maintained. Therefore, they are not used routinely in hypertension except in the presence of renal or cardiac failure.